The doctors look at kidney diseases starting now on call. Funding for on-call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support on-call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. The kidneys remove wastes and extra water from the blood. When something interferes with this process, things go bad quickly. Chronic kidney disease affects 26 million Americans. It can lead to kidney failure and death. Renal diseases, when the doctors are on call tonight.
They call me Mellow Yellow.
Hello and welcome to On Call Television. The kidneys are our unsung heroes of the body, quietly filtering poisons out of the blood while holding on to the important proteins as these double powerful bean-shaped organs filter 45 gallons of blood running through the entire volume of the body's blood 25 times each and every day. From that, there are about 2 quarts of wastewater excreted every day. And yet, when we push our bodies in a desperately needed, to be holding on to desperately needed water, like someone's trekking across the desert, or remove excessive water when someone is over-consuming beer at a Super Bowl party. Sometimes, however, things can go wrong with the kidneys. Diabetes and too high sugars can plug them up. Inherited cysts can destroy their architecture and function. Immune system diseases can attack them. Kidney stones can block them. And infections can eat them up. And yet when they fail for whatever reason, modern healthcare has powerful medicine to protect them and save them or even replace them. To help us answer your questions about these fabulous filters, we have 2 guests who have plowed their way up from Sioux Falls to Brookings and now through the magic of television into your living rooms. Our first guest is Dr. Julie Ann Linatoc, a general internist and nephrologist. Julie Ann, tell us a little bit about yourself.
So, actually, I just recently moved to Sioux Falls like 6 months ago from Virginia. Okay. So I did my internal medicine residency in State University of New York, and then I had my nephrology training and then transplant training at Virginia Commonwealth University.
Okay, so Virginia.
Virginia.
So there's a difference between Virginia and South Dakota. And your home is originally?
I am originally from the Philippines.
So and right now it's summer in the Philippines.
It's always summer in the Philippines.
So there's a radical difference between what you are. And you, welcome to South Dakota. Glad to have you here on our guest.
Glad to be here.
So Bob, you were a prior guest on the show, what, 30, 40 years ago or something like that? Tell us about yourself. Where are you from originally?
From the East Coast. So I've trained all over the East Coast, and then 20 years ago I saw the light and came to God's country and won't leave.
You were drawn out here because of hunting?
No, a guy named Ed Zawada, who you know, and became his partner.
And you've been here since?
It's just a great place to live, raise a family, practice medicine.
Yes, it is. And the 2 of you have been more involved with transplant. Tell us a little bit about how that got. How did you get started doing transplants? I mean, originally, you trained in Virginia on that.
Actually, the reason how come like I chose nephrology is because of transplant. I remember when I was still like a first year internal medicine, I remember we have this patient, like everybody was so scared to take care of her that everybody was in a rush to transfer that patient to Rochester in New York. And then I said, how come like even my attendings who are very experienced with nephrology, they're afraid to handle that patient. So that's what motivates me to go to nephrology and then eventually go to transplant.
So that was transplant in the first place.
Transplant in the first place, yes.
One patient, maybe.
In one patient, yes.
That's very interesting. Bob, what got you into this?
I was originally just interested in kidney physiology, how the kidney works, and I was in the lab, and then I realized that I really wanted to take care of patients, and then I was committed to nephrology, and then towards the end of my second year fellowship, I figured this is, transplant's the way to go in terms of ultimately curing kidney disease.
All right, very interesting. Any questions you have about kidneys and kidney diseases are important, so don't hesitate to ask. On Call is your show, and it's best when you participate. You can call 1-888-376-6225. You may also submit your questions and comments at oncalltelevision.com. Click on the email a question button. And so we ask for your calls. That's the important part that makes this better. So do it early before it fills up and we can't get to your question. Well, let's talk about the kidneys and what they do. This is a picture of where the kidneys fit in our body. They say it's above the belly button, really. It's under the diaphragm. The diaphragm protects the kidneys and the liver. And it's behind the abdominal sac that holds all of the guts and everything within so it's behind in the back area. But let's talk about the physiology of it all. What do they do? I mean, how does it work?
Well, I like to explain it like a water treatment plant. So the blood flow comes into kidneys, the dirty water comes into the water treatment plant. A tremendous amount is filtered into the system, the kidneys, and then the kidneys refine it, filter out some toxins, and then in the tubules, the passageways through the water treatment plant, bad things are taken out and left to exit in the urine, and good things are brought back into the body. So that's the filtering, cleaning system. And then the kidneys also are important in other areas. They are responsible for telling the bone marrow to make blood. They are responsible for making vitamin D and protecting your bones. And so there's a lot of other activities.
So let's talk about the vitamin D part of the kidneys.
Mm-hmm. So the vitamin D, the kidney also produces the active vitamin D. So, most of the time patients with chronic kidney disease or like anyone with kidney problem, they tend to have low vitamin D. So that's why patients that we're seeing at the clinic, those with chronic kidney disease, we always check their bone health aside from their kidney function as well.
So there's this whole story about phosphates, phosphorus. Tell me what are phosphates? Where do they come from in our food? What does the kidney do with them? Julie?
I'll let you answer.
The phosphate is a mineral, and it's in dairy products and meat, and we need it. It's vital for our bones, but when the kidneys don't work, we can't get rid of the excess phosphorus. So it builds up, and it kind of backfires, and it hurts our bones, makes them weak. It allows calcium to deposit in blood vessels and narrow blood vessels. And there's a lot of interconnections. For example, it influences these little glands in the neck behind the thyroid called the parathyroid glands. So a lot of interconnections, but the kidneys help get rid of excess minerals like phosphorus and potassium that have various roles, and if they build up too much, in terms of phosphorus, bones and blood vessels.
Right. And Julie, the issue about bone marrow stimulation, what's that connection?
Mm-hmm. So the kidney, aside from regulating the minerals in the blood, it is also responsible in producing the hormone in order to increase the red blood cells. So when someone has some kidney problem, most of the time they have the tendency to become anemic because of that problem.
Right, so they get low, but we've been able to fix that.
Yeah, and that is by giving that hormone that the kidney is supposed to produce.
Right, erythropoietin.
Erythropoietin, yes.
So that's
Known as EPO for short.
EPO, right. And there's been a whole controversy about, for a while we were giving too much EPO, or what's that story?
Well, we can't fix everything like we think we can fix it. So when the body produces EPO and it makes your blood count normal, everything's great. And when we replace the EPO and we get the blood count up, we find if we get it too close to normal, it can lead to stroke and blood vessel disease. So we have to correct it enough that the patient isn't fatigued, but not so much that there's some negative effects. So we balance, fine-tune it.
All right. So there's a lot of different causes for kidney problem. We have some questions already, and one of the questions is, can it be due to hereditary causes to cause the kidney to quit?
So the most common cause of chronic kidney disease, hypertension, diabetes. It could also be because of cyst in the kidney, so which could be hereditary. There's also some genetic causes of kidney disease. So most of the time, it doesn't pass generation of the family. So that is when we think that someone could have some genetic problem.
Okay, so certainly an inherited thing. It can be, it isn't
Yeah.
always though. What percentage of kidney trouble, people on dialysis, for example, have an inherited problem?
About 5%.
Yeah.
5%. So 95% are due to other causes. What is the biggest? Diabetes?
Diabetes being the most common cause.
50%?
40, 50%.
Wow. So, and what would be the symptoms of a person who has diabetic or that has kidney failure? How does a person present? Julie?
Usually someone with chronic kidney disease, at an early stage, they usually do not have any symptoms. So most of the time, during their routine follow-up with their primary care physician, when they draw the blood work, they just notice that they have this elevated creatinine. So
Creatinine is really the measure, isn't it?
The measure, yes. Or sometimes they found that the patient is spilling some protein in the urine, or sometimes they have blood in the urine.
That separates that whole deal, that the kidneys not only get rid of creatinine and other poisons, but it also holds back the protein, holds the protein within and doesn't lose it into the urine. And that's, if it's failing, they start to lose protein, is what you're saying.
Kidney's a very selective filter.
All right. One of the most important things you can do to stay on top of your kidney health is to monitor your blood pressure regularly.
A good blood pressure is about 120/80. When we start getting over 140/90, that's elevated blood pressure, hypertension. And we don't want that going on for too long, because that can cause damage to your blood vessels and your kidneys too. It does damage to the vessels in the kidneys, and then the kidneys can't function as well. They can't get rid of fluid as well. They can't filter. And thus then that can lead to worsening blood pressure and worsening vessels. And it's a vicious cycle that we need to try to put a stop to. As you get older, your vessels become less able to expand and contract easily, and they become stiffer, and thus your blood pressure gets worse. And you can have damage to your kidney vessels too, and have kidney disease then too. And so as you get older, high blood pressure becomes more of a concern, and your kidneys become more of a concern. And so it's good to get those checked out with a blood test or a urine test that can help detect kidney disease. Avoid too much salt and sodium in your diet and protein. The benefit of exercise cannot be understated. They've done studies taking people who are overweight but exercise regularly compared to maybe some skinny people sitting on the couch eating potato chips, and guess who's actually healthier? You know, the people that have a good healthy lifestyle and that are active and exercising regularly. There's many medications that can cause damage to the kidneys. A common one that's over the counter, like ibuprofen or Aleve, other NSAIDs, non-steroidal anti-inflammatory medications, can cause renal or kidney damage. And sometimes it can be a temporary thing. So knowing it or spotting it and stopping it could help to reverse some of that kidney damage. Sometimes we see people with high blood pressure and it's a matter of cutting back on their ibuprofen to help with their blood pressure and with their kidneys. Bottom line is that it's really important to stay on top of your blood pressure. Even if you think, oh, my blood pressure's not so bad, you know, sometimes it's high, sometimes it's not. Well, every time that it's high, it can be doing damage to your kidneys, and which in turn can help increase your blood pressure, and it can be a vicious cycle. And so seeing your doctor and getting it checked out and doing something about it, whether it's medication or lifestyle changes, can be really helpful.
Thank you, Andrew, for that. Question is, how many of those people on kidney dialysis are there because of high blood pressure in their lifetime that's not been controlled or related?
A large number. The problem is that kidney failure causes high blood pressure, and high blood pressure causes kidney failure. So
which is the chicken and
right.
And
so if you look at the numbers, it'll say maybe 25-30% of patients will be on dialysis because of high blood pressure, but it may be another cause that the patient presented too late, we couldn't figure it out, and they have high blood pressure, and we call it high blood pressure. It's probably a little less, but regardless, if you have kidney disease, high blood pressure makes it worse, no question about it.
But there's been a lot recent. I mean, I just read an article that said if you get too low, the risk of morbidity and mortality starts to go up. It's a J curve, right? So the morbidity comes down as the pressure comes down, and it starts to go up as you go too low. And a lot of it is because the elderly on blood pressure medicines fall when they're going to the bathroom and they break a hip and it kills them.
Maybe. Yeah.
And
maybe.
so they said the ideal pressure was 130 to 140. Mm-hmm. What do you think?
So, I mean, I always tell my patient, I mean, it should be individualized. So, for example, if we have a young population, probably like between like up to 60s,
yeah.
like healthy, as much as possible, we want their blood pressure to be controlled. I mean, for someone who has diabetes or for someone who has kidney problem, I mean, our target, we're telling them like 130 over 80 or below that. But someone like who's very old, especially those in their 70s or above, I mean, there's really no such thing as this is the goal blood pressure for
yeah.
you. I have patient when I was at the VA hospital, I mean, he's okay with blood pressure of like 170, 180, but when we drop his blood pressure, even like 130, 140, the patient is already having like significant lightheadedness, and also up to a point that it also causes further deterioration of the kidney function. So I think it should be individualized.
There's a great answer.
Yeah, you know, you're right. But the study you just talked about, the average age was 73. So that doesn't pertain to, say, a 43-year-old, right, who we might want 130 over 80, but a 73-year-old might be 150 over 90.
Right. But it was interesting, and then they said the best meds is lisinopril, and if lisinopril is not good enough, amlodipine. I was surprised by that. The standard has always been start with HCTZ or one of the diuretics. And the other is that beta blockers. Why not beta blockers? Well, no. Now we're saying beta blockers are not as good. I mean, that's just new stuff. Why is that?
Complicated.
Simple answer now. Don't know. It just
not
is.
Simple. It is. Yeah.
It's just that way.
It would take another hour.
Yeah. Let's not go there.
No.
All right. We have some from Hayward in Iowa. Thank you, Iowa. Is it possible to gain kidney function back after having 8% function and being on dialysis? Are they going to get their kidneys back? No.
Yeah, unfortunately, no. So every time I see a new patient, I mean, as much as possible, especially during the initial visit, like this afternoon, I have a patient that I saw, like, she's very anxious
yes.
because she thought that she'll go to dialysis. So she has a mild chronic kidney disease, and I'm telling her that it's been going on for the past 5 years. But her creatinine or the kidney function has been stable since then. So I'm telling her it's only a mild kidney disease, and most likely that is from your diabetes. She has diabetes for the past 30 years, but it's been controlled though. That's why she doesn't have any complications from the kidney disease. But I'm telling her the damage has already been done. There's no way for us to bring the kidney back to normal. But our goal is to prevent it from getting worse
yes.
and make sure that the blood pressure is controlled, the diabetes is controlled, make sure that they're not on any medication that could further harm the kidney.
Now there's the other thing. They talk about protein in the urine as a result of kidney disease. And for the longest time they said, no, we need to give higher doses of protein in your diet so that you can replace the protein that you lose. And then they changed their mind and they said, no, we need to go on a very low protein diet so you don't overload the kidney with all this protein and destroy the kidney further. And then they came back and said, doesn't matter. Just kind of keep it at a nice balance in the middle. Now, is that where we're at right now?
I agree with just keeping it in the balance. I'm not sure about you, Bob.
Everybody knows what a healthy diet is. You know, it's less red meat, it's more fish, it's grains, it's fruits, it's vegetables, it's low-fat dairy products. And those diets have a limited amount of protein, an adequate amount, but not, you know, a 20-ounce steak is not healthy for anybody for any reason.
So the whole push now, though, is high protein diet, low, zero carbohydrate or very low carbohydrate.
Those are fad diets. That's not the push for a standard heart healthy diet. It's what I mentioned, you know.
A balanced diet. and I think the biggest part, they talk about oxidative damage that foods can cause. It's too much food. That's the oxidative damage.
Hey, you can lower everything if you just cut the portions.
Yeah. From Mobridge, a caller has kidney stones, which she hasn't passed. Why does this happen, and what can she do? Kidney stones, that's a great question. Julie, kidney stones.
So kidney stones, I mean, it could be hereditary, or it could happen like to a person, particularly those like who lives in the desert, or if they're dehydrated.
They're kind of chronically dry.
Mm-hmm. So we usually advise our patient to drink plenty of fluids, at least 2 to 3 liters a day, so that they keep themselves hydrated. Try to avoid high salt diet also.
If you have calcium stones, restricting your dietary calcium will not prevent stones.
Yeah, actually they say more calcium helps. So it doesn't help. There's no good answer. I mean, people really don't have good answer. If you've got gout, make sure that that's controlled. I've heard that. And there's no other real clue. If you've got kidney stones, it's a good idea to push a little bit of fluid. If you don't have kidney stones, pushing fluid? No. People need to drink 8 glasses of water? Or, no. No. You don't need to push all this water.
No, drink what your thirst says.
Who says that?
I don't know who said that.
Everything should be in moderation. One time, I have a patient at the clinic who was referred to me because of low sodium in the blood.
Yeah.
Because she's a cancer patient, so every time she's getting the chemotherapy, she'll get dehydrated. Her kidney is out of whack. So cancer is gone, she's not getting chemotherapy, so every time she goes to the clinic, she'll drink at least 3 to 5 liters of water because
she's just pouring the water down.
She thought it was healthy.
She wants her blood work to be good.
And made her sick.
And the thing is that sodium is very low, so everybody was worried that they referred her to me. And I mean, by just getting the history, I mean, she'll mention to you that she's drinking a lot of water. I mean, everything should be in moderation.
Yeah. I think if you're thirsty, it's a good idea to drink. If you're not thirsty, you don't have to push it.
About the question, though, stones can sit in the kidneys. They really only become a problem when they get to the funnel, the collecting system, the excretory part.
So they can just sit in the kidney, no problem. They start blocking.
Then you're in trouble. Yeah.
20 years ago, Mark Ekeland was diagnosed with primary biliary cirrhosis, an autoimmune disease of the liver. It's no known cause and no cure. The disease destroyed his liver, and he needed a transplant. Well, after his wife's cousin offered to be a living donor and gave him a part of a liver, Mark's life got back to normal, or so he thought.
As I have been treated then with anti-rejection medication for my liver disease, that has caused my kidneys to start to fail. They're telling me, okay, your kidneys are failing, you're in stage 4 kidney failure, and so it's time to start thinking about a transplant or possibly dialysis. My kidney doctors were saying it's much better if you can find a living donor before you go on dialysis, so that you have a higher chance of having that kidney survive longer if you don't go on dialysis. This past December, I had a kidney transplant and another living donor, and it's quite interesting because both of the donors are from my wife's side of the family, both first cousins, not the same person, but my side of the family either weren't healthy enough or weren't a close enough match, which is really quite unique, I think. There are a lot of myths out there as far as why they shouldn't donate, and I think if they go to the UNOS website, also contacting the state of South Dakota's Life Source organization, and they list a lot of things, that questions you can ask or myths that are out there about organ donation that I think can make them feel more at ease with a decision to be an organ donor. An advance directive would be another thing that they could do to make sure that, if they're incapacitated and on life support, that this is what I want done. That driver's license, letting their parents and loved ones know their wishes, and then having an advance directive might be the best way to prepare for a situation that no one wants to have happen.
Wonderful story. Thank you, Mark, for your willingness to do that. Remember to call with your questions at 1-888-376-6225 or email us at questions@oncalltelevision.com. We appreciate your questions. Thank you. Hypertension was the other thing I wanted to we need a balance of that. That is a question. Here's one from Brookings. Can high levels of bilirubin be correlated with pre-existing kidney dysfunction?
Bilirubin's liver.
So bilirubin has nothing to do with it, but it's excreted somewhat in the kidney. High levels, liver starts to fail. You can tell the color in your urine.
Yeah, actually it's still very controversial right now whether someone with a very high bilirubin could block the tubules in the kidney and then cause kidney disease.
Right.
But that would be in the setting of severe liver failure.
Yes.
Right. And really one of the clues that something's happening with your liver is the color of your urine. It gets really dark.
Or your skin.
And your skin and the eyeball. 2 stones removed with laser, blood pressure 125/75 on warfarin, INR 2.12. How can he stabilize his INR range? 2 to 12. How can he stabilize his INR range without medication? So what has happened is this man is on blood thinners, and he's wondering if kidneys have anything to do with the level of his anticoagulation. How do you stabilize anticoagulation? Do you have any clues? How about kidney issues?
Not much. I mean, the kidney function with chronic kidney disease tends to change slowly over time, and so the effect on the metabolism of warfarin or Coumadin is minimal.
Okay.
There are many other things that interact with.
And he had his stones removed. Now, there's a lot of different ways to remove kidney stones. Give me a summary of kidney stones. Depends upon where they are and what to do. Julie?
So one is laser treatment, and then they have what is called like the basket. Trying to extract using a basket.
So you pass a tube up the ureter, this tube that goes up to the kidney, and that ureter, you pass the tube, you into the bladder, and you go up the ureter, and if the kidney stone is somewhere along this ureter, you grab it with a basket. And laser, you just blast it with a laser.
Yes.
Other ways.
Lithotripsy.
Which is lithotripsy?
It's we're not urologists, so I don't know the exact science behind it, but it breaks up the stones. It's a high frequency wave device. It breaks up the stones.
All right. Can we see the on-call man so that we can, let's just take a picture, look at our on-call man, and then come a little closer to that. There are the kidneys. The next picture is, and you see the kidney, and you see the ureters, and the veins and the arteries that feed the kidney, and it doesn't help us much, but okay. But the lithotripsy is blasting it with sound waves. then the person is in a bottle, in a tub of water, and they use, they anesthetize them while they're
That's
laying.
one way to do it if there's large stones.
Sometimes you don't need to be in the tub of water anymore. All right. Horseshoe kidney, and how does this relate to kidney cancer risk, and how does that relate to kidney failure?
So someone with a horseshoe kidney, so meaning instead of like these two kidneys being separate, like they're connected like to one another.
And so they come like a horseshoe here, and they stretch across this way.
So the incidence of chronic kidney disease for someone with a horseshoe kidney is very small, and the progression, I mean, it's very slow. I mean, rarely that they could develop like end-stage
generally
renal
not
disease.
a problem.
They do just fine. Right.
And sometimes it is just diagnosed incidentally.
Oh, yeah. Oh,
but
by the way.
without any kidney problem.
Yeah. By the way, you've got a horseshoe kidney. One great big kidney instead of two. What about the cancer risk? Anything cancer risk that you know? Did you say no on that? No on cancer risk?
For what? For
Horseshoe kidney?
Not that I'm aware of.
All right. What is it called if the kidneys don't retain potassium? Why does that happen? So people are potassium losers. There's a lot of reasons for low potassium. I mean, medicines that most likely cause diuretics. But what else?
I mean, someone with some dysfunction in the tubules. I think we have it here.
Yeah. All right. Let's get a close-up of or right here. Okay.
I don't think it's
Doesn't
here.
really show
It doesn't really show it here. But I mean, the kidney, even though it's a small structure, it consists of a lot of cells. I mean, it also has what we call the collecting tubules. So each tubule, it has its own function. So one of it is to conserve the potassium. I mean, depending, for example, someone with a normal kidney, no matter how much potassium they take, I mean, the kidney should be able to normalize the potassium in the blood. But sometimes there is some tubular dysfunction in the kidney that the kidney just keeps wasting the potassium.
And is that an inherited deal?
It can be.
Yeah, it could be.
Sometimes the tubules are perfectly healthy, but the hormonal system that tells the tubule what to do with the potassium is disrupted.
Well, and people who have
And
excessive...
that can be inherited.
People who have Cushing's syndrome or too much aldosterone, then it can cause the potassium. So there's these hormones, and that's from the adrenal glands, which sit adrenal on top of the renal system. And so the adrenal system can mess up the kidneys and cause the potassium to be low. There's a lot of, if we talked about potassium, we could go on and on for days. But you can inherit some things.
Yeah, it's uncommon though.
If a person has anemia, should they have their kidneys tested?
I would say that there's many more causes of anemia that are not related to the kidneys. So
Right.
not necessarily.
You know, you take care of very old people, and you'll find that many of them have mild kidney dysfunction, and they'll have mild bone marrow dysfunction, just because they're older and that's it. But like you say, people who are bleeding, or people who have weird bone marrow conditions, or people who have toxins, it just goes on and on about the causes of anemia, and renal disease, kidney disease is
one of many. Yeah.
Right. What's the largest kidney transplant patient that's still alive?
The largest?
The longest. Sorry, misread that. 7 feet tall, and I'm sorry.
Probably, I mean, the original from the Brigham from 57 was, I think he just recently died. So, am I right or am I wrong about that?
I have one who's 35, 40 years.
Yeah,
there's a bunch of those.
40 to 50 years, probably some. That would be abnormal, I mean, or unusual. I mean,
What's the average length of time that people live after a transplant?
Oh, live?
No. Their
kidney lasts.
Yeah.
So it depends on the donor. I mean, for example, someone with a living donor, it could last between 10 to 20 years. I mean, of course, depending what will happen, and also depending on how compliant they are with the medication.
And what the match was.
How good the match was. Can you put in a really young, a baby's kidney and an adult? Do they do well?
Yeah,
Yes,
they do very well.
Actually, they
It'll
do
grow.
better compared to
Really? A baby's kidney. We hear about dialysis all the time, but just what is it and what happens when someone goes to the dialysis?
Before dialysis, you're eliminating waste daily. And so we have to do it quite often because then all that fluid and toxins build up over time. So 3 times a week we eliminate that, and patient will come in and get weighed, and we have what is called a dry weight. That dry weight, we try to achieve that weight with each treatment. The blood is taken from the patient, comes over, the pump pulls the blood away from the patient, brings it over to the dialyzer. The dialyzer is the kidney itself, basically, and it's filtering the blood, removing the waste products and the fluid, and then it returns it back to the patient. Somebody who comes in might be short of breath from that fluid that's been building up, might see some edema in their legs, and now over a course of time we're going to try to remove that for them. Monitoring mostly the vitals of the patient here every half an hour or more often if needed. Mostly their blood pressure may decrease towards the end of their run because we've pulled the fluid during the whole treatment. During the course of a treatment, we monitor their vitals, which is their blood pressure mostly, because now we're changing blood pressure because of the fluid we're being removed. So on the screen itself, we have pressures here that is each individual, if they have needles access in their arms, we would be looking at, this is the arterial and the venous pressures. Also monitors if they have a catheter in their chest. This is another pressure gauge. Shows that our treatment is running and that the blood pump is going at 500 mils a minute. So going at that pace, that is one reason we want to make sure that their needles are secure and everything is running well. The whole process of dialysis too is very wearing. A lot of people feel like they're drained and feel like they need to go home and rest. But people can work on dialysis and can be on dialysis for many years, 25 some years. It's not nearly as good as a person's kidney, even one kidney, but it's a very good process.
Very interesting, the whole dialysis story. We have a caller here from an intensivist from Sioux Falls, and he said, if you go below the equator, will your urine flow backwards? Do you think he was kidding? So, sorry, I couldn't help myself. Thank you for the call and the question. So what drugs or herbs are most worrisome to the kidneys? Now, I think this is very important. A lot of people use a lot of non-steroidal anti-inflammatories, naproxen or Aleve, and Advil or ibuprofen, Motrin, or a lot of Motrin or a lot of aspirin. How hard is that on the kidney?
Yeah. So I keep telling my patient, as much as possible, try to avoid those medicine. The thing is, those medicine, the anti-inflammatory drugs, they're very good with the pain, especially those with arthritis, compared than with other medicine like the opioids or like the morphine type medicine. And I think
kind of pushing us toward the opioids.
So it's very difficult to avoid those medicine. So I'm really not like an advocate of not taking it at all. Mm-hmm. So I'm telling my patient, if it is really necessary, you could probably have 1 or 2. But I keep telling them, make sure that you're not dehydrated. Like, for example, if they're having like nausea, vomiting, or diarrhea, or if they're not eating well, as much as possible, try to avoid those medicine.
Right. Tylenol better?
Tylenol is better.
But not perfect.
In moderation, you know, I mean, every day,
day after
6 times a day, nothing is good.
good.
And the same with the non-steroidals, the Motrins and such.
So there's
intermittent use. You sprain your ankle, you need it for 3 days, fine.
Okay.
But not
forever.
Constant use, especially if you have kidney disease.
Right. Now there was some recent data I read about naproxen being better than ibuprofen. What do you think?
Probably for cardiac reasons, for heart reasons.
Yeah.
Yes.
Maybe not quite so
Probably
Who
doesn't
knows?
matter too much if you're going to take a handful. It doesn't matter which one you take.
So the answer is no. Don't go immediately and go with the Aleve. I mean, ibuprofen or Aleve as needed, small doses, not
Intermittent,
regularly.
not regularly. Right.
Right. Any other herbs? I mean, what about the supplements?
So the supplements, I'm not an advocate of that. I mean, the thing is, it's not FDA approved, and aside from the supplement itself, it also has like some metals that
Heavy metals.
heavy metals that we do not know whether it could affect the kidney or not.
So you're not a real fan of a lot of supplements.
Mm-hmm.
Right. Bob, any comment?
The one that's definitely bad is the Chinese herbs.
Yeah.
What's it?
Aristatoric
acid.
Yeah. So
I'm forgetting the name of it, but commonly known as Chinese herbs, those are directly toxic to the kidneys.
all right. So how about for Mobridge, blood clots in the lungs, kidney shut down, blood clotting, bee sting drug? Why do some kidneys turn back on and some don't? So let's talk about an acute
Kidney injury.
Kidney injury, and so kidneys shut down. For example, a period of time where they don't get any blood flow or they don't get any oxygen for a short period of time, and then suddenly they turn on again, but they don't concentrate for a while. So tell us a little bit about that, Julie.
Mm-hmm. So acute kidney injury, or for those who never had any kidney problem then develop kidney problem by the time they're at the hospital, it could be from a lot of factors. I mean, for example, if someone is very dehydrated for a prolonged time, those who's having like nausea, vomiting, or diarrhea, it could cause some kidney failure, but those are only temporary. Or for example, if someone has a bad infection that caused their blood pressure to be too low.
Or blood clots to the lungs and the kidney shut down because the blood pressure went too low.
Trauma.
So what happened probably like with the blood, when someone has a clot in the lungs, tendency is for the forward flow of the blood to be decreased because everything is being pushed on the other side instead of the kidney getting some blood supply. So with the low blood pressure, that one could temporarily affect the kidney.
Acute tubular necrosis, do they still call it that? And so it shuts down for a period of time and then comes back. I mean, I remember seeing that happen once a year. I have a case that's just so sick that happens. But they come back.
They do.
Do they have long-term consequences of that as a rule?
Sometimes.
Okay. Discuss GPA and kidneys. GPA, grade average. No. GPA, no.
GPA.
GP, anything?
GPA.
Kidneys. Protein kidneys, slightly elevated protein, GPA. Protein.
Well, protein spillage in the kidney is important. The more protein you spill into kidneys, the more likely the kidney disease is to advance over time and cause kidney failure.
Okay. And it talks about an age limit from Martin. Age limit for being a kidney donor. Do we have any sense of if that kidney is older?
There's no hard and fast rule, and the limits are being stretched. But generally, it's safe to say that there have been cases of donors in their 70s, but we would not use a donor in their 70s, but we would use a very healthy donor in their 60s.
Okay.
The younger the donor, the better for the recipient, of course.
Right.
So it all depends on the circumstance of the donor's circumstance, the recipient's circumstance, their relationship, the function of the kidneys for each one, the size of the person, the match.
Any comments that you want to make sure we say about donation in kidneys? I mean, there's been recent articles about how harmful it is to the person who's donating.
Actually, so before they could become a donor candidate, we make sure that they're healthy. Actually, there's this study comparing the general population versus who donated the kidney.
Yeah.
Ironically, they live longer or they have a lower mortality
Than the general
than
population.
the general population. But it doesn't mean that someone has to donate a kidney for them to live longer. I think
Right.
it's just the fact that like the general population, they only go to their physician by the time they're already experiencing something that probably it's already late before something could be done.
You may have picked a better, healthy person.
Right. You would expect that the people that we're using as donors, since they're very,
very
very healthy,
healthy.
they should have a better life expectancy. We do know that for young, perfectly healthy donors, it's
just
minimally
very,
increased.
very safe.
Right. It's, there's an anesthesia risk to getting your appendix out or delivering a baby.
But that's it.
Right. The limits are being pushed. So.
Okay. Tonight we're launching a new feature for On Call. It seems we often talk about the importance of healthy eating on our show, no matter what the topic is. Each week we will take a moment to visit with our dietitian, Katy VanderWal, about how the food we eat impacts our health as it relates to our program topic.
Diet is something that's going to have to be watched for anybody with kidney or renal disease, whether it's phase 1, phase 2, phase 3, phase 4, or end-stage renal disease when you're receiving dialysis. However, everyone's diet prescription is going to be different on a renal diet. The typical nutrients that are watched in a renal diet include potassium, phosphorus, magnesium, and also sometimes sodium. The level of these nutrients that you're able to take are going to vary depending on a patient's fluid status level and also depending on the nutrient levels in their blood. Your dialysis team, your doctor, your dietitian, and your healthcare team members are going to help you know how much you're going to need of these nutrients, what you need to restrict, and also what foods are going to have these nutrients in them. Dietitians are always available to patients with kidney disease, whether it's directly on the dialysis unit or in the outpatient clinic to help them be educated on their diet restrictions. The recipe I chose tonight to share with everyone is chili for your kidney diet. It's a chili that's going to be lower in sodium and also lower in high phosphorus ingredients. Chili con carne, 1/2 cup onion, 1 stalk celery, 1/2 cup green bell pepper, 1.5 pounds of ground beef, 16 ounces of low sodium stewed tomatoes, 1 tablespoon canola oil, 2 tablespoons of chili powder, and 1 1/2 cups of water. First, you'll want to chop the onion, the celery, and the bell pepper. Put it into a large, warm skillet on medium heat. Add the oil along with the onion, celery, and pepper. Cook until tender but not brown. Add the ground beef, breaking it into small pieces and cooking until brown. Blenderize the tomatoes and add them to the beef. Add the chili powder and water, mix thoroughly, reduce heat to low, and simmer for several hours. This is going to equal 3 meat exchanges and also 1 vegetable, which is a medium potassium vegetable exchange, with no carbohydrate choices for the diabetic who's also on the renal diet. And a helpful hint is to serve this with low sodium crackers to restrict your sodium intake in that area as well.
Thank you, Katy. And we like the idea of a diet plan. Give us your feedback on that. Okay, we've got tons of questions. We don't have answers. We're going to get to the questions after the show and put them on the internet if you need them. Fast answers. What about matching, kidney matching? Any words about what matches work best?
The higher the match, the better, but you don't need to match.
Don't even need to match. Caller has renal artery stenosis and a stent. What's your thoughts about that?
If it's
very important. I mean, blood pressure is a big clue, isn't it?
Yeah, he or she should do fine if it's stented and open. Follow up.
Okay, 3 to 4 cans of diet soda a day. Is that a bad thing for the kidneys? No.
It's bad for them.
It's bad for everything. I think that's probably not a big deal as long as you're healthy. Otherwise, kidney disease, the phosphate may be pretty problem. Are there certain foods that are good for the kidneys, like asparagus or anything? Any particular good foods?
No, just general healthy diet.
What about statins? Do statins injure the kidney any, or do they help the kidney?
Probably neither, although lowering the cholesterol might help.
I agree.
Okay. Caller wanted to tell us he has had his transplanted kidney for 38 years. Thank you.
Outstanding.
Oh, where is that?
That's from Sioux Falls.
Sioux Falls.
Okay, another from Sioux Falls. Can you mention general guidelines for safe amount of salt and alcohol for the kidneys? Salt. Is that a big deal? Are we making a bigger deal of salt?
If you have totally normal kidneys, salt's probably not a big deal. If you have kidney failure, restricting salt to 2 or 3 grams a day would be
And nothing about alcohol? A glass of wine is probably good.
2 a day.
It's okay.
2 glasses of wine a day.
No more, no less.
Okay. All right. We'll be back right after this.
With 2013 behind us, our thoughts turn to romance. That's right. We're entering a time of year symbolized by none other than the flu bug. Did you know flu season usually doesn't peak until February, sometimes even later? Why take chances? It's not too late to get vaccinated, because stopping the flu starts with you.
Joe was a 60-something diabetic patient arriving at the emergency room swollen, very short of breath, and with fluid leaking from sores over his pitting, swollen legs. His swelling puffiness, or edema, worsened the legs, extended up all over his body, even around his eyes. When his kidneys were tested, we found elevated waste in the blood and protein in the urine, indicating the kidneys weren't effectively excreting waste products, and yet were losing important proteins into the urine. We also learned his diet was terrible, his diabetes was out of control, his prostate had been troubling him for years, and his heart pump was weak after a heart attack 5 years earlier. He was one sick fella, problems piling upon problems, and so we admitted him into the hospital. Edema, that puffy, swollen, sock-denning problem formerly called dropsy, is very common to the human condition and can simply be due to poorly functioning veins and their tiny venous valves. Poor veins are treated by support hose and/or elevating the legs. Edema can also be due to a weak heart when the pump doesn't have enough push and pull to either push the blood through the kidneys or to pull the blood back to the heart from extremities and from lungs. Mostly, heart weakness is treated with diuretics and medicines. Sometimes in men, the prostate will block urine flow enough to slow down kidney function, causing edema. This can be fixed with catheters, prostate surgery, or prostate shrinking medicines. But the most challenging cause for edema happens when blood levels of that egg white-like protein get too low. This makes blood thin and watery so that fluid leaks out of blood vessels and into tissue. Low blood protein can be due to several problems: a diet lacking in essential protein building blocks, a liver that isn't making enough protein from those building blocks, or kidneys that no longer hold on to those proteins as they are filtered, resulting in protein lost into the urine. Low blood protein is difficult to treat. Indeed, Joe's problem with edema had several causes. We treated him by elevating and wrapping his legs, by medicines enhancing the heart pump and removing excess fluid, by a catheter opening up urine flow, and finally by improving nutrition and diabetic control. Long-term kidney problems won't go away for Joe, but for now, we could help. After a week in the hospital, Joe lost 20 pounds of water and went home without a catheter, breathing easy, leg sores healing. Well, this brings us to the end of our show this evening. Each week we look forward to the questions from you, our audience partners. Unfortunately, we often run out of time on the show to answer all of them, and to improve on this, we will now, after the show is off the air, record answers to many of those questions. To view these, just visit our website at oncalltelevision.com and click on the archive button for answers to questions we couldn't fit into this evening's show. It may take a day or two to get them posted, but your questions are important to us and we don't want to leave them unanswered. Well, I sincerely thank our studio guests, Dr. Linatoc and Dr. Santella, for helping to answer all the questions about kidney diseases from our audience tonight. The 3rd century Roman Emperor Marcus Aurelius suggested, when you arise in the morning, think of what a precious privilege it is to be alive, to breathe, to think, to enjoy, to love, and even to go to the bathroom. Maybe I added that. Until next time, stay healthy out there, people.
Funding for on-call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Healthcare System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.